So, good afternoon, everybody. My name's Emily Lafredo. I'm with Concord Hospital Trust, and I'm pleased to welcome you to What's Up, Doc, a monthly lecture program brought to you by Concord Hospital Trust. Concord Hospital Trust would like to recognize and thank the Walker Lecture Fund for their generous sponsorship of What's Up, Doc. The Walker Lecture Series offers a wide variety of programs on history, literature, art and science, as well as dramatic, musical, and literary performances. All events are free to the public and held at Concord City Auditorium. We encourage you to check out their website at walkerlecture.org, view their calendar of programs. So, What's Up, Doc is proud to welcome Dr. Bill McCann of Affiliates in Podiatry as our guest physician today. Dr. McCann practices pediatric medicine and surgery with Affiliates in Podiatry located at Concord Hospital Pillsbury Medical Building and at their Lakes Region office in Meredith. He serves as immediate past president for the New Hampshire Pediatric Medical Association as a treasurer and treasurer of the American Pediatric Medical Association Political Action Committee. Dr. McCann is an avid runner and enjoys all distances from mile to marathon, and is a member of the Rock and Race Event Committee, where he serves on the logistics team. Personally, I can thank him for that. He's wonderful at his job. So he and his wife together have completed all 48 4,000 footers in New Hampshire and continue to enjoy hiking in the White Mountains. Please join me in welcoming Dr. McCann.
Thanks for the kind introduction, Emily. I really appreciate it. And thank you to Concord Hospital Trust for having me here today, and all of you for coming. A day almost doesn't go by in my professional practice where a patient doesn't ask me, how did you pick podiatry? How come feet? And it's really, I give them the pat answer. That's basically that friends of mine, an undergraduate, went to podiatry school. I had an introduction to a podiatrist that was just down the street, and when I was in college, went and spent time with him in his office, and it was just a perfect fit for me. But I think the story really goes back a lot further to my parents. My mom and dad are here today as a guest at the lecture, and so my dad was an athletic trainer in the NBA and in Major League Baseball when I was growing up. So when I was old enough, he'd bring me to work with him. And, you know, it's pretty cool. You go, you see what the athletes and everything do. But my interest was more in what he was doing. And, you know, in the NBA, there's a lot of foot issues and ankle issues. And it was really cool to, you know, see that, the interaction with the team doctors. And what was really cool is how quick he could tape an ankle. So I always thought that was really interesting, and I think my mom caught on to the fact that I was interested in medicine. So you know, she would encourage me to take a look at that as I was growing up. Well, when I finally got to be 18 and it was time to go to college, as most 18-year-olds' ideas are not always connected with reality, I was thinking I wasn't going to go into medicine just because I didn't like math. I didn't want to do calculus as one of the core requirements. So she got me in front of one of the advisors, and sure enough, you know, he convinced me, calculus is easy, you can do it, and so here we are. So, I certainly have my parents to thank for that guidance. So we're going to talk today about a number of things. On the agenda is basically what we do to help patients. And we're going to talk about what a podiatrist is, some common foot and ankle conditions, and what we're doing to try to keep people comfortable and on their feet through what we do in the operating room and mostly what we do in the office. So the burning question, what is a podiatrist? And basically, we specialize in foot and ankle, just about everything you can think of. Skin, nails are a real common thing that we see in the office. We also deal with bones, arthritis issues, all kinds of different problems, bunions, hammer toes, nerve problems, a lot of sports medicine. Our older patients are always very surprised to see how many young people are in our reception room. So we treat all ages. And our training is basically 4 years of an undergraduate degree, taking the core requirements, which includes calculus, and taking MedCats. And then we do 4 years of a postgraduate medical degree at a College of Podiatric Medicine around the United States, and then a three-year hospital-based residency, which is usually in surgery, and then finally a fellowship is optional. So there's overlap with podiatry, as in many specialties in medicine. We have our main overlaps with dermatology, orthopedics, and vascular. And our colleagues in these specialties are who we generally and frequently collaborate with on patient care. Now, common foot and ankle conditions, there's many that we'll cover today. And basically, when patients come into the office, what they're interested in is, what is my problem? How are you going to treat it? And about how long is it going to take before I get back on my feet comfortably? So we try to answer those questions in each of the things that we're treating whenever possible. And we'll start with something that we see every day in the office, which is fungal toenails. And they're basically caused by a dermatophyte, which is the same fungus that causes an athlete's foot infection. That is almost always the way that fungal nails started, with an athlete's foot infection. You know, the itching, burning skin between the toes or on the bottom of the feet. Usually easy to treat. Once it gets into the toenails, it can take a very long time for it to come to roost, and it's difficult to treat in toenails, but easier today than it was years ago. This is something that has to be differentiated from melanoma when you have a dark spot like this in the nail, and we typically we have an electric file that we could just smooth down the nail, and it typically takes out almost all of that black substance, and then we just watch it carefully. If there's any suspicion, then we would just do under local anesthetic, a biopsy of the nail plate in bed, and then send that to dermatopathology for further diagnosis. And the nails can come in lots of different shapes and thicknesses when the fungus does infect them, and we'll go through some of those in just a minute. But this can be a risk, especially to patients with diabetes, because they have neuropathy and they may not feel the nail digging in, which can create a secondary bacterial infection, which can really actually be dangerous to them if it ends up going deeper and then infecting bone. But there's 4 basic treatments for fungal toenails, and patients ask about all kinds of things for treating their fungal nails, and most of them are harmless, but they won't work. Things like Vicks Vapor Rub or other things you may have heard of. Some over-the-counter preparations are not going to do a very good job. And the 4 treatment options that we talk to patients about are oral medication. It still is the gold standard. And mycologic cure, which means it cured the fungus, is about 72 to 81% of the time. It's a very, very good result in most cases. Now, it takes the full growth cycle of the nail until you see what your final result is. You're looking at least about 9 months to a year before you have nice looking nails. A lot of people are really disappointed when they come and see me in April, hoping that they're going to have beautiful nails for the summer. It's not going to be that summer, but the next summer that they're going to look good. So a lot of our patients, as you might be aware, if you've ever seen a podiatrist yourself and this treatment was offered to you, you might not be a candidate for this medicine. You do have to get liver function tests, and it is a safe medicine, but it's something that you really do need to keep a close eye on and test and follow patients through. So topical is oftentimes the default treatment for patients. Now, it's very good for mild to moderate disease. The picture you have up here is more into the severe disease category, especially on that big toe. And we talked about the athlete's foot before, and you can see the skin right around here on the toenail is looking kind of red and is peeling. And almost 100% of the people that have fungal toenails also have an athlete's foot infection associated with it, at least around the nail folds. The topical efinaconazole 10% nail solution needs to be used once a day for 11 months, and that gives you about a 52 to 54% mycologic cure. The disappointing part about mycologic cure, which means the fungus is cured, and what the patient actually has in front of them can sometimes be disappointing, because if the patient has a toenail that hits in the front of their shoe, for example, if they have a hammer toe, they get microtrauma, and microtrauma looks a lot like fungus, so you might have a sterile nail when you're finished, but you still might have a thick nail that's not beach-worthy. So it does become a little problem that we like to explain to patients. Also, there are many lasers that are out now that are used by podiatrists and dermatologists to treat fungal toenails. The one we use has two wavelengths that are specifically designed to interrupt the fungus cycle and then to clear the nail. It may only be a temporary clearing of the toenail, but it actually can be much more effective on the thicker nails than the topical medication, because the topical medication is really for mild to moderate disease. And finally, a permanent toenail removal is often used if patients have chronic pain. So here's what some fungal nails look like. There's a superficial white onychomycosis, something that's just on the top of the toenail. Easier to treat, really. This one is more thickened nails, as you see. Even that toenail on the left has a little in the corner. Then we have this nail here, which is ingrown. Deformity of the toenail can happen with this. Also, you can see how the nails also get curled from the fungus on those three nails. Ingrown toenails can become infected, obviously. When the infection is bad enough, as in this case, you have to anesthetize the area with some lidocaine and do an incision and drainage. We slant the nail back and then drain the abscess, and if necessary, put the patient on antibiotics. The good news is most of the time a nail looks like this. I wouldn't put the patient on oral antibiotics. I would almost certainly just let the drainage do the job, and they'll use a topical antibiotic on it, and we can avoid that in most cases. Ingrown toenails. This is what on the left one looks like right after a procedure that's done for people who get them chronically. You know, if it's the patient's first time having an ingrown toenail, we just drain it or just slant it back, and that usually does the job quite well. But sometimes it's a chronic problem and it recurs and it drives them crazy and it hurts at that point. We just go ahead and take the borders out, and then we cauterize the growth matrix or ablate the growth matrix with a chemical called phenol, and it's an 88% strength. It does a very nice job. Also, this is my wife's toenail making a cameo appearance in the lecture tonight. And so a little reflective with the pedicure that she got, but I took the picture for a reason. I did her what we call chemical matrixectomy 30 years ago, and it's doing fine. And so it really worked out very well for her, and you can get your pedicures and do what you want afterwards. So warts, they're called verruca. They're viral in nature. They are contagious. You should spray shoes with Lysol, shower surfaces with Lysol. You should also wear a pair of flip-flops to protect yourself and others. And basically, there are as many treatments for warts. It would be an hour discussion on how many treatments there are and whether or not they work. What we do is we debride these, because on the bottoms of feet, they get callous. We apply a medical acid, and then that it's not like what you get over the counter. It's very potent medical acid that has 30% salicylic acid as well as cantharidin and podophyllin. So these are blistering agents that will help make the wart go away over the course of time. They have to come in and have them debrided and reapplied. The skin on the bottom of the feet, unfortunately, is rather thick, so it does, even though warts are only skin deep, the skin is thicker, so they take a little time to get rid of on the bottom of feet. So at first glance, you're probably thinking more warts, and these are calluses. And to the to anybody sitting here, or even oftentimes patients, doctors will look at it and say you have a wart, go see the podiatrist. And we treat these just like warts in many cases, particularly the one on the lower right, because when you have that lesion like that, you can put the medical acid on, and that will help to make that feel much better. It's a friction response of the skin to the underlying bone that's creating this problem, and not so much, it's not a viral etiology, and so they come back. These do have a rather high recurrence rate because you typically don't have to address the bone, and patients can stay comfortable for long periods of time with usually just with filing them down and utilization of a 20% urea cream or something along those lines that will actually reduce the callus. Bunions are hallux valgus. There are many treatments for bunions, and we're not going to get into all of them. There's just too many to do that with. Basically, you see the x-ray here. What you have is an increase in the intermetatarsal angle, the angle between the first and second metatarsals. The big toe migrates over. There's two small bones right under here called sesamoids, and they migrate to the lateral or outside of the foot along with the great toe. It's a syndrome because the muscles and tendons also will start to stretch and change as a result of the bunion over time, and they do get worse over time. This is a hereditary problem, and so it's passed down in families. If you have it, you can usually treat this, and we almost always do conservatively, typically shoe stretch, padding, and orthotic. These kind of biomechanical treatments work very well. Sometimes if patients have enough pain, we can give them a cortisone injection to try to put surgery off. And in most cases, we can treat it without having to go to the operating room. When it comes lately to bunion surgery, you're probably hearing a lot about the instrumented three-plane hallux valgus correction. And basically, this is a more minimal technique to treat bunion deformities at what is thought to be the typical apex of the deformity, which is at the first tarsometatarsal joint. And so it basically is a three-plane correction with utilizing instruments that make the surgery much more accurate and easy to do. It has a very good fixation construct, and then it allows the patient to bear weight in just a few days in a surgical boot, whereas before, a surgery like this may have taken as long as 8 to 10 weeks on crutches. So there's been a lot of changes. There's many systems out there that are doing this, but I bring it up because you are probably seeing the advertisements, and if you do and you think you're a candidate, the best thing you can do is go see a foot and ankle specialist and ask if you're a candidate for it if you have an interest. We use a lot of locking plates. This has been around for several years now, but really represents a good quantum leap for patients in terms of especially their recoveries. It has excellent union rate, higher than other fusion rates, but with similar functional results. This does allow us to help the patient to bear weight sooner. Nobody wants to be on crutches for 8 weeks, I can tell you that, and so this is a really great procedure for that. It's used with arthritis of the great toe joint called hallux rigidus, but we also use it for severe bunions in some cases as well. I'll share a case study with you. This is a patient of mine. The patient presented initially with a wound that was infected between the great toe and the second toe. Then the wound was, job one is infection control, so we debrided the wound. We treated it with antibiotics. We made sure that that was all healed, and the patient was still complaining about significant pain. So at that point, we took the patient to the operating room, and as you can see on the slide on the left, there's a rather significant increase in the intermetatarsal angle. The big toe is drifting over against the other toes. These sesamoids are moved over, just like the picture I explained to you before, And the patient had quite significant osteoarthritis of the great toe joint, which can happen with long-standing bunions because the mechanical position is now changed and it erodes the cartilage in such a way that they do develop osteoarthritis with bunions periodically. So we took the patient to the operating room and used this actual plate, and basically there's special instrumentation that allows one to make a ball and socket out of this joint, it denudes the cartilage, and then we can really put it where we want to, and it helps to reduce the intermetatarsal angle. The angle between these two bones, as you can see, has changed, and it helps to allow the patient, again, because of the stability of the construct, to be able to weight bear much quicker. Yes, question?
Toe is also beginning to bend. Would that be corrected just by correcting the bunion part?
No, the second toe is beginning to bend, and we left it alone because the patient was really having no pain at all with the second toe. So that was very, very good observation. This patient did not need that done. She did ask about it, and generally speaking, we don't do anything with something that doesn't hurt unless it is a real issue getting a shoe that they can't find a shoe that fits properly. And of course, you do need to have a discussion in a case like this with the patient if they love to wear flip-flops, because there's a bit of a gap here. Some of it will close down, but that is tough to wear that kind of shoe afterwards, and most people don't care. But it is a discussion you should have to make sure that their expectations are met as far as the surgery is concerned, or what they may not be able to do. So,
thank you.
Yeah, you're welcome. A tailor's bunion or bunionette. Does anybody know why they call them tailor's bunions? Well, tailors used to sit cross-legged on the floor to do their work. And so after doing that for many hours during the course of a day, the outsides of your feet hit the floor and they got irritation around the joint. And so hence the name tailor's bunions. And they're treated a lot like bunions are. We do less work with tailor's bunions because they can typically, a lot like bunions, be treated with conservative care. And hammer toes. This is a hereditary problem. This is something that gets worse as time goes on, just like bunions. Frequently you'll see a hammer toe with a bunion, especially the second toe, which will come up across the top of it. There may be a neuromuscular component to why this is happening, although it is oftentimes difficult to find out exactly what that neuromuscular component is. And usually, just like bunions, shoe change, padding, the conservative care, they may get a corn on the top or the tip. These are now often treated in the office, and there's good evidence that, especially with older patients, tenotomy is a very effective treatment for a hammer toe, provided that it's not too rigid. And most of the time, you can straighten these toes to the point where the patients feel very good. And it's a very simple procedure where we just place a nick in the bottom of the skin underneath the toe, and then just clip the tendons underneath, and the toe straightens right out. And then you may have to do this joint here too, but usually it's just underneath the toe on the bottom, and it straightens the toe out. It typically works very well for patients, and especially it's just a couple of days of recovery of just taking it easy, and then you're back into a regular shoe pretty quickly after that. Yes?
Is there a correlation between like someone's foot arch and the type of like injuries or diagnosis like hammer toe or bunions? Is there a correlation?
There is a correlation. People who have flat feet or who pronate tend to develop bunions, hammer toes, and things of that nature. So in certain instances, there is a correlation. It's an excellent question.
So like definitely recommend like going to like for like running shoes or sneakers in general. Like there's definitely some shoes that are meant for higher arches or flat feet, and anything that's critical in picking the right pair of shoes.
in picking the right pair of shoes?
Yeah, just for your feet health.
It-
Is there a difference?
There is a difference, and it's a loaded question. And the reason why I say that is the proof of the pudding is in the eating, as they say. And so you've got to be comfortable in the shoe. Now, I will make recommendations to you or any patients that come in. In fact, this is a lacing guide. We have this whole handout that we will give to patients with different shoe brands, and we'll talk to them about which one to use, or at least which one to go and try. Now, being a runner, I can tell you a bit about some of the running shoes and which ones I would recommend you try. But I have been proven wrong by so many patients over the years that I have learned to make the recommendations in a bit of a guarded fashion, but as long as I give them the disclaimer, they can get a good start with a good shoe. Shoes are made with, most companies are making them with a range. Like if you're an overpronator, the company's going to have a shoe for you, and if you're somebody who has a high arch foot, they'll have a shoe for that too. You can talk to the people at where you get sized. Go somewhere where you get sized, like a running store or a good shoe store, and talk to them about, especially at a running store, if you're looking for a running shoe, on what there is that you can use. But there's a lot of really good shoes out there that it's something for a whole hour of discussion. Yeah, you're welcome. You're welcome. Okay, well, any questions about hammer toes? Okay. We're going to talk for a minute about point-of-care ultrasound. This is really growing in many specialties in medicine. Point-of-care ultrasound basically provides immediate, cost-effective data that can augment your diagnosis. In many cases, that immediate information is going to really enhance the patient care. It can, in cases, obviate the need for an MRI. This is a really nice way to do it. Point-of-care ultrasound is brought to the patient. The patient is not brought to the machine. And so you can bring this with you into the treatment room. It's literally an iPad and then a transducer that functions in many ways that can actually be used in many specialties, and you can pick whatever you want to use it for. We just use it on musculoskeletal mode. And so I've shared with you some of the images that I captured. These are basically stored securely in the cloud. If you choose to do so, there's thousands of providers on a network that you can collaborate with about the ultrasound studies that you did. It's safe and a very, very effective tool for patient education when you're doing it and it's indicated to do it. I like to use it to show the patients exactly what's happening, and it's a really great tool for that. So I'll show you some images. This one is a picture of the back of the heel, and this patient has a bone spur right here. There's the Achilles, and it's fairly swollen right here. There's a lot of blackened signal, so there's edema there. And this is a common condition, just an insertional Achilles tendonitis. It's very good for finding partial or total tears in the tendon, and you can glean a tremendous amount of data from these. Also, here's a partial tear of a tendon. You can see the tendon sheath is just hypoechoic signal or dark signal, which means fluid. So that's a typical appearance. Here's plantar fascia. The plantar fascia, there's a little line that goes up and down right here. And on the slide over on your left, it's a smaller line. On the bottom, it measures 0.38 centimeters. That's what normal is 0.2 to 0.4. So that's what basically normal with a little bit of swelling in it right here looks like. And then this one is a much worse, 0.82 with a lot more swelling, to give you just an idea. Now, ultrasound can be used also as a tool for needle guidance for injections. And we give cortisone injections for plantar fasciitis. and they can be very helpful, but I usually don't use it as a first-line treatment. It's certainly not anything that anybody enjoys getting a cortisone injection, but it can be very, very helpful. And so we do stretching, we do NSAIDs, like Advil, ibuprofen, Tylenol can be used as well. We tape the patients, we use night splints, send them to physical therapy. We have other treatments that we'll talk about as well, and orthotics. But pain, plantar fascia thickness, and plantar fasciitis recurrence are reduced when cortisone injections are utilized along with the ultrasound. So what we have here is, here's the needle, here's the plantar fascia, and this is an off-plane picture, so it's giving you a cross-section of the needle and not a longitudinal axis of the needle. And that's typically how we do it and how we get it in the right place. You can do it by feel, but it's much better to have this, and then there's studies that demonstrate the utility of it for that particular kind of injection. Now, ultrasound-guided cyst aspirations are good for ganglions if necessary. Some of them are just really easy. You don't need to have an ultrasound to do it. And here's one that's been annotated and measured. And then also you can see the needle right here. And that's like a deeper cyst. So this is an ultrasound of interest because sometimes ultrasounds or cross-sectional imaging look a lot like nature. If you look at that,
Yeah, it does.
it's really interesting. We had a great lecture about MRI of the foot and ankle by a radiologist from Jefferson University. He must have had 20 of these. It was really, really funny. And but I found one of my own. This is actually one of my own scans, and I always liked it because it just looked like that. Often we use extracorporeal pulse-activated therapy. This has its roots in extracorporeal shockwave therapy, or ESWT. This it was used first by urologists to break up kidney stones so that the patients can then urinate them out. It's a very common thing that they use this for. There's multiple generations of these machines. At one time, we were using the same generation of machine that they were using, but it became more evolved into units that are and can be used in a doctor's office. These larger machines are typically about $500,000 each, so they're not really something that you can necessarily invest in a practice, but they made these great EPAT machines that offer an excellent treatment. They're multiple treatments versus just one treatment, and we don't have to do them under local anesthetic, which is really nice for the patients. They're based on acoustic pressure waves, and we use them predominantly for plantar fasciitis and Achilles tendonitis, both insertional type as well as paratenosynovitis of the Achilles tendon itself. So how does it work? Well, it basically can create, not in every patient, but an analgesic effect. So it affects the nociceptors and makes the patient feel much better almost right out of the gate, but not in every case. And we explain to patients that this is short-lived. This may not last any longer than the time that you come in for your treatments for your fasciitis or Achilles tendonitis, because after that it may just go away. But it's nothing to worry about because we're looking to get revascularization. This is very much thinking out of the box. We're looking to create some swelling, not take it away, which is what everything else we're doing is trying to do. We're looking to have more revascularization process, and as you can imagine, that takes months to happen. So the patients don't really start to feel a real result for about 3 months and even up to 6 months before they really feel better. So you have to have that discussion so that people understand what the mechanism is and why it takes some extra time. There's an analgesic effect, obviously, as we talked about, circulatory, and it can accelerate healing and break down adhesions. And we talked about how this all works. It's a microtrauma or neo-revascularization process, and it's been compared to meat tenderizing. You know, I'm trying to, you know, get those juices flowing again, so to speak. Again, the common conditions are on the bottom of the foot, where plantar fascia is typically located at the heel, although it can be in the medial arch, and then at the back of the heel in the area of the insertion of the Achilles tendon, when patients may have a subcutaneous bursa or retrocalcaneal bursitis, or on the body of the Achilles tendon itself.
Sir?
Now we'll talk, yes.
Would that work with other muscles around joints?
Yes, it will. We have used it for this right here, posterior tibial tendonitis, also for the peroneal tendons. We've used it for that as well. So you can use it around on the other areas. We just don't use it as frequently there, but you definitely can. There are more studies for the plantar fasciitis, which was what was FDA approved for ESWT, extracorporeal shockwave therapy, around 2002. That was what was FDA approved to begin with. And so there's a lot more experience treating plantar fasciitis and Achilles tendinopathies with this type of technology. So, okay. We'll talk a little about skin substitutes, and the ones that we use are dehydrated human amniotic chorionic membrane allografts. An autograft is a graft that comes from you, like a skin graft that is taken from you and put onto a site. And an allograft is something that comes from another source. So these come from another source, and we'll explain how they're harvested. These are very suitable for in-office use. They're excellent. They have a good shelf life. They're stable. They're dehydrated. You can get them fresh frozen from different companies. You can get them. You can get them in a variety of different manners. This is the one we're using, and it has very good studies. It's used predominantly for challenging diabetic foot infections that are failing from the usual wound care that we do, which is usually debridement. It's usually wound care products like an antibiotic dressing, collagen wound care products, foam wound care products, even collaboration with the wound center. So when things are not working out, then we will introduce a graft, and this is basically how the process all starts. Expected mom is introduced to the donation program. They're screened and sign a consent. They have to deliver a healthy baby via cesarean section in the United States. Following that, then the donated placental tissues are removed, and then they undergo microbiological testing and making sure that they're suitable for use. Then they get sterilized, and then they're ready for packaging and shipping. And that's how these come to us. This is after birth that would have normally just been discarded. Skin substitutes they have very, very good studies behind them, 91 to 97% wound closure in 6 to 12 weeks, and 94% remain closed after 9 to 12 months. This is just what they look like, the ones that we're using. Typically, we're using a disc or we're using a mesh, depending on the size of the wound. Yes?
How was this ever discovered to do that?
It was discovered by an ophthalmologist and an eye doctor. And they were using it it was being used in ophthalmology for many years, and then it just went out into more wound care.
It is so amazing.
Mm-hmm.
It is so amazing.
It really is. I mean, I have to say, it even amazes me. It doesn't work all the time, but it works very well on some very tough to treat wounds.
But to think to be able to take something from a placenta.
Mm-hmm. It really is truly amazing. It's something that would typically be discarded. So, But it has it has properties that allow for wound healing. It's a very long explanation, but it has it has an amniotic and a chorionic, or a baby and a mom side to it, and so it has some it has regenerative properties and things that can help wounds to heal, and that's why it works.
Just so amazing to me that somebody is intelligent enough to discover that, to even think about it. That's what amazes me.
It truly is amazing. I
Human
definitely
brain
agree.
amazes me.
Dr. McCann?
Yes.
Is there ever a chance that tissue would be rejected because it wasn't connected, it was somebody else's tissue or came from, have you ever had that experience?
No, and to be honest, I am not aware of that with the product that I use. It's not something that we have ever seen. So how we use it is we measure the wound, we trim the graft, we put the graft on the wound, and typically we have to wet it with a little saline. Then we use a secondary dressing, typically like a petrolatum gauze or something along those lines, followed by a secondary dressing. So the primary is the petrolatum gauze, the secondary being the regular gauze, and then we just wrap that up with some gauze and Coban. Now, these patients should really be off weight bearing on this, because it's really going to challenge the graft ever working if they can't get off of it. So in the forefoot, if the patient can't get off of the wound, we'll give them a wedge shoe, and the wedge shoe will keep them off of it enough that the graft can work. So but you do need to do everything you can to keep the patients off weight bearing on these. Here's a typical wound that had been debrided for approximately 8 weeks until it got to a good granular base, followed by 4 graft applications, which helped it to go on to healing. We'll finish up with fall risk. Fall risk is really something we're seeing more and more of today. As you might imagine, we see a lot of patients who come into our office who are older, who have foot pain, and who really need to be talked to about falls, because foot pain is probably one of the primary reasons it may happen. However, the first thing here, multifactorial, is what's really important. What we're really looking for is fall prevention by mitigating risk. And so how we do that is really through screening and through working with a team of people that are going to help the patients to stay safe and on their feet, which makes such a huge difference in the quality of life. And so everything we talked about kind of comes around to this in terms of what we see and what the risk factors are. So we talked about a lot of foot deformities here and how they create foot pain. And we also looked at how they really can affect your flexibility. Patients with neuropathy and diabetes, they get wounds, but they also fall. They also have falls because they can't feel their feet. And so you put these together, they may be on some medicines that are making them dizzy or have side effects. They may actually have dizziness issues. You have to really target and look at what is happening. And so it all comes together with everything we talked about here, and we can really do a lot to help patients reduce their fall risk. We make changes. We try to work in conjunction with primary care doctors and physical therapy, and we talk to the patients and especially talk to their families, because really it's this whole group of people that are going to make things much better. It's important to do this because it's very, very expensive. First, it happens way more frequently than anybody really imagines, and it really affects the quality of life of the people that are falling. So we want to do something to try to mitigate that risk and keep people on their feet. And so the foot and ankle problems that we deal with in the office help to mitigate foot pain, but we're also looking at patients with an eye towards balance and how do they walk, and how do they, how is their gait? We look at a lot of things, and we'll go through that in just a second. And this is really well studied, that what a podiatrist can do along with a team can really make a difference. And we treat these corns, calluses, and things that maybe seem a little bit mundane, but can create a lot of pain for people, and that really makes a difference. Patients should be on an exercise program, even if they're just doing the ABCs with their ankle, just to keep their muscles moving. And then we can work with them with footwear and ankle and orthotics and ankle foot orthoses, which we'll cover here. And the CDC recommends that patients are screened for this kind of thing to find out what is their fall risk. And so we just use a simple assessment form here that has a few simple tests. It takes about 10 minutes, and then we just detach the half of it here and give the patient the instructions for exercises they can do at home. And then it talks on the back about vitamin supplements that they can consider, and talking to their primary care providers about their medicines. So this is really the way that this works with a team, because it really can impact a patient and their families. Gait balance disorders, it's been well studied, and it's a common cause for falls in adults. And also the fact that it's multifactorial, we need to target interventions in which we can help patients with their falls, and that too is well studied. And basically, in the early 70s, patients in their early 70s, 25% of them have a fall. And that goes up when patients are in their early 80s to about 60%. So the incidence increases over time, and so it's really important as the patient ages that we keep an eye on this. The 4 key components that I hang my hat on for this are basically some means of screening, and I showed you the screening tool, and I'll show you the simple test that we do. There's 2 others that we do, but the one that I have here is a good standard test. Getting the patients to physical therapy or occupational therapy is really critical to strengthen and also help to work on balance. Ancillary services, DME, we start with canes or walkers. That's always a tough one. And it can help when family members are there, but when it comes time for a cane, it's a real good idea. And it can really save physical injury and really damage to the quality of life. So we highly recommend it. Getting the home safe, getting rid of scatter rugs, things like that. And also, the ancillary services for durable medical equipment would then carry into orthotics or ankle foot orthoses, and then, obviously working with the primary care provider with education on falls as well. So we use the tug test, and basically all that is you ask the patient to sit in a chair, you say go with the timer, they stand up, they walk 10 feet, they turn around, they walk 10 feet back to the chair, they sit down, you stop the timer. That's it. And then you watch them to see how do they walk, slow, tentative, do they shuffle? Is their speed variable? These are things that can lead to falls. And so what we use, if the patient has had PT, if they've been working with their primary care provider, and if they use a cane or a walker, now what we do is and they're still feeling unsteady, not confident, or have had falls, now we're talking to them about getting into an ankle foot orthosis, which is custom fabricated. And these basically, they're easy to use. They are put inside the shoe and left there. The patients will slip right into these, and it's just like donning your shoe. It's already in there, and that's the nice part about it. It makes it really easy. Reduces postural sway. Patients always will tell you, yeah, I keep falling backwards. So it helps them to have more awareness. Their proprioception, which is kind of your awareness in space, improves. It also helps to increase stride velocity, a critical indicator for falls. and it also helps to reduce the variability in stride. This is a really important point. If people are not afraid of a fall, they're going to be more active, and they're going to be really able to get out and enjoy themselves and stay healthy. And there's a noticeable increase in activity trends when we get to the point where we have to use one of these. There is more studies necessary because the falls have not been quantified. We don't know how many falls can be avoided, but we do know that they reduce the risk by reducing those critical factors that we talked about to help patients to stay on their feet. And I'll show you here how we take the impression. We use a 3D camera, and just one of our medical assistants just walks around the patient's foot, ankle, and lower leg, and they capture the cast. You could do this with orthotics too, but we typically still like some of the more old-fashioned kind of bespoke casting or biofoam boxes. This does work very, very well. I was a little nervous the first time we did it and wasn't sure what the final product was going to be like, but it came out absolutely perfect, and it works very well. And this is what it looks like in the patient's shoes. This is somebody who typically is going to need a walker and had unsteadiness, and they're able to, with physical therapy and the other targeted interventions, plus the ankle-foot orthosis, are able to walk much better. There we go. So because of the need of more studies, a focus group was formed, and they went about looking for more evidence that these ankle-foot orthoses are as beneficial as we think that they are, and that the other studies have provided us with evidence that they are, and that the custom foot and ankle orthoses do reduce the fear of falling and definitely have a great potential for direct reduction in falls. And it really helps with the psychological trauma, the fear of falling, everything we talked about in helping to keep people safe. And
Okay.
we're all done. So I'd like to take any questions that you might have. You asked them along the way, which was great. Yeah, yes, Warren.
Hi, Bill.
How are you?
I'm well, thank you.
Good to see you.
Excellent presentation.
Thank you.
This question is not going to be medical at all. It's kind of a man-on-the-street question, I think. Could you give us an overview of your perception about what shoes are healthy for feet? I mean, you see kids walking around with flip-flops, all varieties of shoe wear. In order for us to maintain healthy feet throughout our life, what kind of shoes should we be wearing, or should we not be wearing?
It's an excellent question. First, I like people to get a supportive shoe that's comfortable. I do prefer tie-up versus slip-on. You're going to get a lot more stability from a tie-up shoe than you are something that you just slip on. I like a shoe that has a removable insert. So it has an insole in it that gives you some support but is removable. Also, the shoe needs to be breathable. You know, sometimes a leather shoe can be quite uncomfortable, especially if you have a problem with foot perspiration, etc. So you want a shoe that has a breathable material, and most of the shoes these days are made that way. I like shoes that have flat laces versus round laces, because the number of people that have pathology on the top of their foot, or the instep as everybody calls it, is much more than you think. And a round lace can cut right into that and really make it uncomfortable. And you have to couple the shoe with the right sock. So the sock should be something that wicks moisture. Smart wool socks are great because they stay warm, or so they say, after they get wet. I haven't had too many experiences like that, but I'm always I'm always the first guy to get cold, you know. That's just me. But wool socks or smart wool socks can do that. So you want a good sock that's going to wick moisture, that's going to be comfortable, and that's going to interact well with the shoe. If a patient wears orthotics, then you definitely want to have a shoe that has the removable insole to it. So those are just some pointers that I look towards. And you get more specific with runners sometimes because they're looking for something a little more. And beyond that, those are the basics. I hope that answers the question.
Yeah, well, I mean, so I'm curious about the flip-flops that kids wear. Some people wear these really, really flat shoes, and a lot of them are overweight. I'm wondering, how in the world can they do this and have their feet be comfortable, or going forward, are they really setting themselves up for trouble?
Going forward, they're probably setting themselves up for some trouble. Now, that said, I wear flip-flops, and I'm 60 years old. So, but I wear something that has some good support to it. There's so many flip-flops out there that do. And you got to pick the time you're wearing it. You're not going to want to wear the flip-flop. You're setting yourself up for some trouble if you're going to wear that flip-flop when you go to Disney World, or if you're going to be walking for 10 hours during the course of a day. But if you're just wearing it from the car to the beach, or just going out for ice cream or something, you're probably not going to be setting yourself up for too much trouble. I remember very well, we went into my wife and I were just finishing up Mount Pierce. It was 4:30 in the afternoon, and there were 3 young college women going up that mountain. 2 of them had Chuck Taylor Converse on, and the other one a pair of flip-flops, and they couldn't wait to get up to the top. Honest to God, we're halfway down. I think they might have just tied with us to the parking lot because they actually made it. But you are setting yourself up for a lot of problems, especially if you pick the wrong flip-flop or the wrong sandal-type shoe, because then you're going to create an injury to a tendon or a ligament. You could even get a stress fracture. These are the problems with those kind of shoes.
Have you actually seen the shoes advertised on TV that are sneakers that once you lace them, you can step in and out and don't have to lace and unlace all the rest of it? Have you actually seen them?
I have. There's.
He has a pair of them on right now.
You have a pair of them on. There's a lot of sneakers that have speed laces. I know some of the more popular manufacturers make some really interesting kind of slick systems. Some of them they are very nice for people that have trouble with their laces and things. So, here we go. We have. This is like a day of my life. I mean, this is normal. These are nice shoes. So you like these? These comfortable for?
They're comfortable, and she doesn't have to bend down to put them on. She just puts her foot in, stands on it, and the back collapses.
Because it has that, yeah.
And so it's very easy to put on and very easy to take off.
Yeah, this is a nice shoe for somebody who doesn't want to bend down. They also have these speed laces that you're talking about. And again, they help you to be able to get in and out of the shoe without having to bend over and tie them up. And that is hard for some people.
Yeah, but it's not just that. It's the lacing and unlacing. It takes time. No trouble. I have no trouble bending down, but our laces take a lot of time out of your life. You want to take your shoes off when you get in the house, and many people do.
Mm-hmm.
Put on some other kind of shoe.
I'm sorry. Go ahead.
The slip-on, like Jim likes his slip-ons when he gets in the house.
Could you repeat what she's saying? We can't hear that.
Oh, sorry.
Yep.
You want to say it? You can say it louder.
Yes, she's just talking about these stretch laces and the ease of slipping them in and out of your shoes, and that something like that can be very very useful and helpful.
Dr. McCann, I imagine, to follow up on Dr. Emily's question, that you see the crazy shoes that people wear and you think, that is job security.
It certainly is. I guess it's a love-hate relationship for me, but it certainly is job security. In the back.
Yes, now we're talking about shoes. I think another thing that I do see Converse, and it might be maybe they can't afford professional like weightlifting or CrossFit shoes, but I always see people like when they're lifting weights, they're always in Converse, and I'm like, I cringe because I think that's just bad for your arch and your heel, but then they say, but it's a flat surface, but I just think that it's just maybe that people wear shoes that are just, so do you have any like opinions about the Converse, like the flat, is it bad for like your heel and your arch?
As long as you're not wearing it for too long, or it's a lot about what are you picking for the activity that you wear the shoe. I wouldn't go running in them. I probably would recommend an orthotic if you were going to engage in some sports with a shoe like that. A weightlifter, somebody who plays basketball, etc. They do make, Converse makes great shoes, and they make some that have more support than others. Some of those old retro ones don't have as much support. They're just, and I'm sure that's what you're referring to, kind of the Chuck Taylor older ones. And you know, that back in the day was all there was, but now they have much better support in the shoes. So I would be careful with those shoes. They're much more of a fashion or popular shoe, and maybe should just be reserved for that kind of thing versus using in the gym or something of that nature, because you could be prone to an injury.
I bet this topic has come up in your office, although it's not your specialty, but a lot of cat owners like to convince themselves that removing a claw is no different from removing a human toenail. What do you think?
Well, I don't know much about removing a claw, but I can tell you that I think sometimes I had a conversation with a vet about it, and sometimes they like do they take the bone out. They do like a small amputation that has the growth matrix or root in it, and they do it that way. I don't know if they use chemical. They're both viable methods on humans too. However, I couldn't tell you what the exact it's probably not apples to apples so much, but they're both kind of the same thing in a way, because they're a means to an end to get rid of a toenail.
Does a toenail that's been removed, does that just grow back naturally, or do you replace it with an artificial one, or how do you treat?
A good question. We don't use artificial nails. We remove it so it doesn't grow back, which is really the purpose, because what happens if you just remove a thick toenail like some of the ones that you saw, it will grow back exactly the same. It's not going to change what you have. A year later, you'll have the same exact problem, the same thing. So to prevent recurrence, we just remove the entire toenail, or if just the corners are bothering, we'll just take the corners out and then cauterize the growth root with the acid. There are many other ways to do it, but that's just the way that I do it. And most podiatrists in the United States are using the phenol technique. So it doesn't grow back, and we don't want it to. If it does grow back, then we consider the procedure a failure, and we have to redo it, or the patient just decides to live with it. Yes?
This may be a controversial question, but you see these foreign athletes from Africa, they run barefooted. They've been barefooted all their lives. So do they develop some of these arch problems and stuff that we need to wear shoes with arch supports and not go flat with flat shoes with no support?
Well, that question is, it sort of leads to this whole birth of this movement of the zero drop shoes. The shoes, most sneakers and shoes have about a 12 or 13 degree wedge to them, even though you may not notice it. But they do. And the zero drop shoes are flat. They're perfectly flat. And they made a number of different minimalist shoes, I should say, initially, based on the fact that the thinking is that the people that do go barefoot like that are better off. That's what somebody who studied those folks found and decided to come up with this whole movement. Now, from a personal standpoint, I saw a lot of people 10 years ago adopting those shoes and using them, And some people did okay with them, but I did see some injuries too. There are still zero drop shoes, but most of them aren't as minimalist as they used to be, but have a pretty good sole to them. So they do make those shoes now still, and that kind of was the birth of that whole movement. So there was a lot of controversy that went along with it.
Follow up on her question, would you advise people to just go barefoot as much as they can?
No, I wouldn't do that, especially with some of the conditions we just talked about. I wouldn't do that. And plus, you could step on something, and a lot of my patients have neuropathy, and I worry about, like, they're going to step on something if they don't have a shoe on, and now they're going to get an infection. And so I typically don't recommend that.
In the last few years, maybe 5 or 6 years, sneakers have been made with the toes rising up considerably. Is that a good idea? This has a slight rise.
Like that?
Could you repeat the question?
She said, yes, I can. She said in recent years, sneakers started to have a toe that kind of goes up like this. It sort of slopes up like this, almost like a rocker bottom on the shoe. And your question on that was whether...
Is that good?
Whether or not it's good. It actually kind of just really remains to be seen. Not all manufacturers are doing that with shoes. And for some people, it's a wonderful thing. It can help you to kind of rock over things in the forefoot. For example, if you have a neuroma, or if you have pain under the ball of your foot under here, I call it the ball of the foot because that's what everybody calls it. If you have pain underneath the metatarsal heads on the bottom, it can allow for a little bit easier motion over those.
Okay. Thank you so much, Dr. McCann. Great
Thank
talk.
you.
And
Thank you.
all of you for coming today. We are in the process of scheduling out the next 6 months of What's Up Doc, so pay attention to our website and emails to know what's next. And on behalf of Concord Hospital Trust, have a wonderful weekend and stay healthy.